just to set the scene, I'm a professor of primary care, and the research I do is genetic health service research, which is, unlike the speakers before, I don't do much science. In fact, the last time I did science was in a Middlesex hospital. But what I do is about translating science into practice. But my interest in FH precedes my curiosity from a research side. It's, as with many speakers here, it's actually patients that's brought this on. And missing a 40-year-old lady of mixed African and Caribbean descent who had an MI in my practice with someone who's interested in genetics was a real shocker. You don't get the sinking feeling, how did I do it? But fortunately, she had children that we could help. So on that note, let me go to the first slide. So this is a slide from the UK. It just states the obvious, but it's great for policymakers that actually FH is as common as childhood diabetes. But the big key issue is we're missing about 85% of patients. And this is, when I go out to practices, this is the first slide I show them, and this is what gets them engaged, as well as the free meal, of course, but this gets them engaged. But what I'd say is, a lot of people say, we can't engage primary care, we can't engage family physicians. But part of it is to do with thinking about the science, not the science of FH, but the science of implementation. What do you need to do to drive implementation? And this is the basic principles. You need to integrate it within national policy. And if you're using electronic health records, use them to their maximum. And some of the tools we've used are patient-specific reminders, audit and feedback, and toolkits for case ascertainment. So just to start off with the policy. In England, there's a policy to provide cardiovascular risk assessment for everyone aged 40 to 75. So this provides an opportunity. I don't want to go through this slide in great detail. This is the master plan, how this works. But critically, it has two important attributes that need to be done in the risk assessment: the cholesterol and the family history. And there's a meaty document that comes with this, and we can provide it for you if you're interested. And in there, there's one paragraph. And the paragraph reads, there's no specific thresholds for assessment, but if the cholesterol is over 7.5, consider FH as per the guidelines. You can read it all if you like, but I'm going to flip to the next slide because. So the guidance was out in 2008, and several of us were involved in writing this guidance. It has been well received, but it hasn't been implemented fully. So our first attempt to do this, to get this policy into practice, is been to write articles. And these articles have had very simple take-home messages. For instance, that think about FH if you've got a cholesterol over 7.5. Think about FH if you've got a patient that's come in with premature MI. Ignore cardiovascular risk assessment tools when you manage these patients. So very simple messages to the population. But as in the US, guidelines are just guidance. Practitioners can ignore them, but what you need is to have some teeth to these guidelines. And one way that in England they're trying to introduce teeth is putting quality standards on them. And what these quality standards do is they performance manage the commissioners of care and the providers of care. And two of the standards that are highly relevant for primary care are, again, if the cholesterol is over 7.5, assess for clinical diagnosis, and refer. One issue is, and we've had it previously when you talk to primary care commissioners, is I can look after these patients in my practice. I don't need to do anything outside. So how are we trying to tackle this, and how does this link to the electronic health records? In the UK, we use the Simon-Broom criteria, and I'm sure you've picked this up from the last time. Two aspects of the possible diagnosis that's relevant to primary care is if the cholesterol is over 7.5 and if there's a family history of MI or total cholesterol. So the way we've tried to evaluate this in our feasibility study is do a computer search for people over the cholesterol threshold. And where we've picked up these patients is to do family history collection using a family history questionnaire. Actually, this works better now. So what the objectives of our feasibility study is two-pronged. Is firstly to actually look, can we put patient-specific reminders to improve the uptake, and compare it to just mailing out to all the patients on the list. And as it's a feasibility study, we're also looking at the recruitment and retention of these participants. Should have spoke too soon, didn't I? So the reminder we're using is very simple. If the cholesterol over 7.5 is documented in the patient's records, when the GP starts a consultation, this reminder comes up. Because it's research, it's got more than that. It just simply says, exclude secondary causes, give them a pack with the family history questionnaire, and repeat the fasting lipid. So what have we found so far? We've gone to 6 practices with about 31,000 patients. Of those, over 900 had cholesterol over 7.5. We recruited about 13% of those patients, and 3% actually have possible FH on the Simon-Broom criteria. 927 is around about 19 patients per 1,000, or 190 patients in a practice of 10,000 GPs. Also interesting in this study is 16 patients we couldn't identify because the family history wasn't clear. This slide demonstrates 2 things. Firstly, it shows the proportion that I've picked up opportunistically by the reminder, and that's the sky blue column. Secondly, how many by the mail out. And as you can see, it's up and down a bit. But also what we were keen to do as well was to ensure we captured patients from deprived practices, which is the inner city practices. And the response rate there was much lower, about 14% of patients, whilst in the affluent practice it was about 22%. And I think if we do any research on implementation, it is vital that we do cover disparities. And it should be in inner city as well as more affluent areas. The other aspect of the study is audit and feedback. At the beginning and at the end of the study, we provided the GPs with information about how their patients are doing. So we identified how many had cholesterols over 7.5, how many, in this case 11, had already got a diagnosis. I won't go through all of it in great detail, so that left 43. In this practice, 19 of them were actually recruited, and then it gives you performance of the practice over that time period. So how many still have a cholesterol over 7.5? How many have they actually recorded the cholesterol? How many have you actually looked for secondary causes, which is the thyroid hair? And also, as well as statins, what about lifestyle change? So we also looked at dietary advice, weight management, exercise, smoking cessation. And this can be provided in real time as often as the GPs need. And from the implementation research, this is highly effective in actually changing behavior. I'll rush through the next slides a bit quickly because I've only got 6 minutes. One of the problems with this is you pick up a lot of patients that have high cholesterols, 200 in the practice. And when we get feedback from GPs, they can't deal with that number of patients. So we need to prioritize. And one way we've done this is to develop a new algorithm. And if people are interested, I can go through this in great detail. We've looked at a database of about 12 million patients, found about 5,000 with FH, and about 3 million who've had a recording of cholesterol. And we've developed an algorithm based on that. And from the algorithm, from the analysis, we found that actually, as you would expect, a high cholesterol makes you more probable to have FH. Triglycerides make you less probable. Often patients in primary care who have got a diagnosis of FH are already on statins before the records were started. And as you might expect, high potency statins is more related to FH, less likely if you've got secondary causes. So we put this together into a algorithm and using ROC curves to show predictability, when you look at routinely available data, you find that the actual algorithm performs better than the attributes from Simon Broom. But as interesting is that if you exclude the secondary causes, the performance doesn't drop that much. But if you include more comprehensive family history, the performance is better. If you drop it out, the performance falls down. So it's no point giving people an algorithm. You have to give them a toolkit they can use. So what we've produced is an audit interface for the practices, where they can identify how many patients they have, how many of the cholesterols they've recorded, and how many are at the threshold where you should actually screen them for FH. And in this slide, there's 56 at that threshold. But if you look carefully, 7 of them, I don't know if there's a point on this, is it? 7 of them actually have cholesterols over 7.5. But if you go back to that data, you find actually those 7 are people who are sort of in their 60s, who have got high cholesterols. So it's no point bringing them in. But also there's another 8 that were seen by the algorithm as having to be brought into the clinic. And those would often be young people who actually got really high cholesterols. Sorry, not young people. This would be people on high-potency statins who hadn't been recognized previously, or strong family histories. One issue that limits collecting this information automatically in primary care is the poor recording of family history. This is a slide we did looking at the quality of recording of family history over 10 years. And basically, if you wanted to look at the relatives affected and the age of onset, which are the red and orange plots at the bottom, there is really poor quality of recording. If we want to enhance the identification of FH, we need to improve that quality. To demonstrate that another way, the toolkit I mentioned, at the back of it has an Excel spreadsheet for the GPs. And what this slide demonstrates is 2 things. Firstly, the no means that the family history of familial hypercholesterolemia, family history of MI, or family history of raised cholesterol has not been recorded. So it gives the GP instantaneously what information is missing that would enhance the assessment of probability. The green column gives the predicted relative risk of FH. You'll notice the first column, there's no recording of family history, but it's a really high relative risk. And in that case, that is a lady in her 30s with a cholesterol of nearly 9. So in that case, the GP doesn't have to really send out a systematic family history questionnaire. They could just bring them in for full assessment. But the other aspect we want to do to improve this algorithm is give them another column where it gives you the relative risk if there was a strong family history. So it can give them a prioritization if they were to collect family history questionnaire information and this person was high risk, what would be the impact of that? It's great collecting all this information, but how do you operationalize it? And similar to what Graham was saying about organization of care. And the way we propose this is if someone's over the age of 16, look if their cholesterol's been assessed. If it hasn't, if they fall within the vascular check program, make sure they do have their cholesterol assessed. If it has been assessed, run this algorithm, rank people from high probability to low probability, and then set a threshold locally according to the prevalence of the condition in your area, and then those people are invited in for a full assessment using Simon Broom, using Dutch Lipid, what other assessment tool gets developed. And those that are assessed high on that are then referred into the specialist service for cascade screening. Sorry, I rushed it a bit. I wanted to try and get within the 15 minutes. So I'm just going to end with a thank you slide at the end. And so it's my local team, it's Steve and Jennifer, Christine and Joe, but also we've had great support from Steve Humphreys and Andrew Neal. And as important, we have a consumer representative on our board. I think a couple of you know Phil Rowlands from Funky Medics. He's been great to support this. So with 12 seconds remaining, I'll say thank you from the floor.